Hello fellow students, today we are going to talk about acute pericarditis. It is one of the most important topics in cardiology that is frequently asked about in every question bank you can find, and a very critical topic for exams also. For this channel and for every topic, we discuss the definition, etiology, pathophysiology, clinical features, diagnostics, and also the treatment. So I want you to get organized and can understand and memorize every topic by heart. According to our schedule, we are going to talk about first the definition. When we talk about acute pericarditis, what do we mean by that? Okay, acute pericarditis is the inflammation of the pericardium. Okay, so we see inflammation of the pericardium. So acute pericarditis is inflammation of the pericardium. So what is the pericardium? The pericardium is one of the important structures in the heart. Is a fibroserous sac that encloses the heart and is formed of two layers. So remember that it is a fibroserous sac. So the two layers are fibrous outer layer and serous inner layer. Okay, and the serous inner layer is also divided into visceral inner layer and parietal outer layer. Acute pericarditis is the inflammation of the pericardium. And now we can go and talk about the most important aspect in studying acute pericarditis, and that is etiology. Regarding etiology, regarding etiology, as most other clinical conditions, infectious pericarditis is the most common cause of acute pericarditis. So we can mark our etiologies by numbers. Here we add 1, and our first etiology is infectious pericarditis. So infectious pericarditis, as the name implies, it is due to an infection, and pericarditis can be caused by viruses, bacteria, fungi, or even parasite. But the most common causes of infectious pericarditis are viral infections. So most commonly due to viruses, and the most common virus that causes infectious pericarditis is Coxsackie B virus. We can also Coxsackie B virus is a very important virus, is also frequently asked about, and can cause acute pericarditis, can cause hand, foot and mouth disease, can cause pleurodenia and other conditions. But for today's topic, Coxsackie B virus is the most common virus to cause infectious pericarditis. So regarding other causes, we have what we call as bacterial pericarditis, and bacterial pericarditis can be caused by a wide range of bacteria. We have whole of the staphylococci species and the streptococci species, but the only one I want you to get really focused in is Mycobacterium tuberculosis. So we can add it here as bacterial pericarditis. We have so in questions, this is a very important information you should know, as in a number of tricky questions you will find it, and Mycobacterium tuberculosis will frequently be the answer for that question. So we now talked about viruses and bacteria. Now we should talk about fungal pericarditis. So regarding fungal pericarditis, the information that I want you to know and dig it deep into your brain, that fungal pericarditis does only infect an immunocompromised individual. So you find fungal pericarditis in AIDS patients, and also fungal pericarditis could be found in patients with long-standing use of corticosteroids. As an example, and the most numerous populations that long-standingly using steroids are people with autoimmune diseases. So very important aspect here. And now we can talk about the parasitic pericarditis. So parasitic pericarditis is lowest yield infectious pericarditis you will find, but the only information that I think is important here to know that it is caused by Toxoplasma gondii. So this is our first etiology, is infectious pericarditis. For other causes, we have myocardial infarctions. So there is two types of pericarditis related to myocardial infarctions. We have A, post-infarction fibrous pericarditis, and B, we have, and is an important one here, Dressler syndrome. So those two I want you to differentiate between them, and how you can do that is mainly by time. So if you have a patient, okay, that was admitted to the hospital, let's see, like a week ago or 5 to 7 days ago, and is now brought back to the ER room with no features of myocardial infarction, just due to sharp retrosternal chest pain. You can put it in your head that it may be due to post-infarction fibrosing pericarditis. So post-infarction fibrosing pericarditis is mainly occurring in 1 to 7 days following the infarction episode. But Dressler syndrome, on the other hand, only occurs after several weeks to months following the infarction, and is an autoimmune process. Okay, so Dressler syndrome occurs in weeks to months following the infarction. Now for number 3, we have post-pericardiotomy syndrome. So post-pericardiotomy syndrome, when you hear this term, I want you to think about surgical operation, because it is strongly associated with cardiothoracic surgery. Okay, if we want to define it, we will say that it is an autoimmune febrile pericarditis that occur 1 to 6 weeks following cardiothoracic surgery. So post-pericardiotomy syndrome, I want you to think about thoracic surgery, okay, and it is in 1 to 6 weeks period after the surgery was done. So number 4, we have an important cause, and that is uremic pericarditis. So uremic pericarditis is due to hyperuricemia, and that hyperuricemia have multiple causes to happen, but the most commonly asked about may be acute or chronic renal failure, and also I see it in several questions as a tumor lysis syndrome, and may be also associated with HUS, hemolytic uremic syndrome. So uremic pericarditis is acute, chronic renal failure. Also we have tumor lysis syndrome, and also the HUS, or the hemolytic uremic syndrome. So for number 5, we have autoimmune pericarditis. So autoimmune pericarditis is associated with several important autoimmune diseases that are rheumatoid arthritis, systemic lupus erythematosus, and scleroderma. So if you want to fully understand autoimmune pericarditis, you should understand those diseases. In this video I will just tell you the names, and if you want us to do another video regarding those conditions, tell us in the comments. So autoimmune pericarditis associated with rheumatoid arthritis, also SLE, and scleroderma. So for number 6 we have radiation. Also important information that usually asked in UWord is radiation as a cause of acute pericarditis. So in radiation there is two types of acute pericarditis. So the first is exudative pericarditis, and the second is constrictive pericarditis. So as it for what we talked about previously in myocardial infarction, the most important feature to differentiate between those two are the time period in which they appear. Okay, for exudative pericarditis, it is characterized by rapid onset during or shortly after the radiation exposure. So here, rapid onset, and as you have already guessed, constrictive pericarditis has a slow onset in a period of years of frequent radiation exposure. So that's it for radiation. Now for number 7 we have neoplasm. Okay, here the only information you need to know is that Hodgkin lymphoma is associated with acute pericarditis. So we can add it here as only Hodgkin lymphoma. And for our final etiology is idiopathic. Meaning that acute pericarditis for an unknown origin or a cause. So by that we finished etiology. Now let's talk about the clinical features involving acute pericarditis. So in acute pericarditis, the most important clinical feature that when you recognize it in a patient should light up in your head. Acute pericarditis is chest pain, and acute pericarditis is one of those conditions that have a characteristic chest pain, and we call it a pleuritic chest pain. So what is pleuritic chest pain? Pleuritic chest pain is a sharp retrosternal pain that is aggravated by coughing or deep inspiration and relieved by sitting and leaning forward. Okay, so is a sharp retrosternal pain that is aggravated by coughing and deep inspiration and listen here carefully, relieved by sitting and leaning forward. So add that here. Okay. Most important thing that you should memorize and keep it in your head for clinical practice is that it is sharp retrosternal chest pain that is relieved by leaning forward. So this is the most important feature you should know regarding clinical features. Now let's discuss diagnosis. And diagnosis in acute pericarditis have a certain criteria that should be met in order for diagnosis or to consider diagnosis of acute pericarditis. So here so regarding diagnosis, there is a diagnostic criteria of acute pericarditis that contains 4 components, and in order to reach a diagnosis, at least you should have 2 of the following 4 components to meet a diagnosis as acute pericarditis. So what are those 4 components? We have number 1 is characteristic chest pain that we talked about. So we have here chest pain. Okay, and for number 2 we have the typical ECG of acute pericarditis. So typical ECG. So what is a typical ECG of acute pericarditis? In acute pericarditis, typically you will find diffused ST elevation and BR depressions. So here ST elevation plus BR depression. So for number 3 we have an auscultative feature that is pericardial friction rub. That is a very characteristic sound that you can hear in patients with acute pericarditis, and I will add it here, so listen carefully. So what you just heard is the pericardial friction rub, and is heard best when the patient is sitting up and leaning forward during expiration while auscultating in the left sternal border. So we can add it now here. So for number 4, we have new or worsening pleural effusion. So new or worsening pleural effusion. So in order for you as a clinician to investigate and to find those 4 components, you should undergo certain types of investigations. So how could you find out that your patient has chest pain? Okay, the chest pain, you should find it by doing proper history and physical examination. Okay, by doing proper history and physical examination, you can find that your patient is now okay, has chest pain. And also by a proper physical examination, you can detect the pericardial friction rate. So how you can find ECG is simply by doing ECG. Okay, and now how you can know that your patient is having a pleural effusion. So you can tackle that by doing chest X-ray, and if you are a well experienced clinician, you can also know that by your physical examination. Okay, now I would like to talk about imaging in patient with acute pericarditis. Is a very important modality in diagnosis and is usually used in cases of diagnosis uncertainty. So now we can add it here. Okay, the first line for imaging at acute pericarditis is echocardiography. Okay, it's echocardiography, and if the echocardiography is not certain enough, you can go for the second line, and that is cardiac MRI. Cardiac MRI is also considered the best modality to assess the pericardium. Okay, now we finished diagnosis, so let's head for treatment. So regarding treatment, and as future physicians, the most important task of a physician is the treatment of your patient. If you done all of what we talked about and you don't know how to treat, it's a problem. So let's talk about treatment. In acute pericarditis, generally all the cases are self-limited, okay, by 6 weeks from the onset of the condition. It's a very important information here. So, and here is usually self limited, but for every etiology you should consider the specific treatment for that condition. Okay, usually we add NSAIDs plus colchicine, and this is mainly for symptomatic management and to relieve the patient in order to reach full health. So by that we reached the end of our video. I would like to know what you think about that, and if you have any questions, and leave it in the comments, and it would be a pleasure if you subscribe and leave the like here. So see you in other videos.